Right. Hello and welcome everybody. Welcome to all our participants and our panelists. Thank you for joining this 1-hour webinar. And thank you to the Faculty of Pharmaceutical Medicine for hosting this series. I'm Zoya Panahloo and I'm very pleased to be moderating today's session as member of the Ethics and Practice Committee of the Faculty of Pharmaceutical Medicine. The format will be very participative and we encourage you to please submit your questions via the chat function. The topic for today is we're focusing on rare diseases and what has been the impact of COVID-19 pandemic on people living with rare diseases. There are some of you who have joined in who perhaps don't know much about rare disease and others of you who are more familiar with it. So just quickly in summary, there are over 7,000 known distinct types of rare and genetic diseases and over 400 million people affected globally. Therefore, it's not a surprise that this pandemic has had a significant impact on patients globally. And so I'm delighted to have today with us a panel of 4 colleagues, and each in their own individual way, they've made significant global contribution over many years to improving the lives of those living with rare disease. And they've been central figures in supporting patients with rare disease to help navigate them and their families and carers through this health emergency crisis. So I'm delighted to welcome the 4 panelists who've taken time out of their busy schedules to be with us for this 1 hour. We have Professor Huma Chima, welcome. Hi Huma. Pediatrician, pediatric gastroenterologist and hepatologist at the Institute of Child Health in Lahore, and which is also a Centre of Excellence for lysosomal storage disorders. We have Tanya Collin-Histed. Hi Tanya, welcome and thank you for joining us. CEO of International Gaucher Alliance. We have Emily Crossley, co-founder and joint CEO of Duchenne UK. Hello and welcome. And Dr. Heather Lau, who's a neurogeneticist and pediatric neurologist at New York University School of Medicine, and also director of the NYU Lysosomal Storage Disorder program. So let's now start straight in with the questions and the discussion. And as I mentioned, please submit your questions and we will try and get through most of them as we can. So maybe I'll start with Heather Lau. I remember at the start of the pandemic when there was a lot of uncertainty and anxiety and not many people knew what the virus was and how it would affect a lot of the patients in the rare disease population. You had these series of really reassuring and calming videos produced for patients and carers, which I thought was really, really timely, and that covered all diseases. So we know that you're actively engaged in clinical research and you're involved in a number of studies and you have a large practice of rare neurological disease patients that you manage. So how has this pandemic had an impact on your practice and your research and patients?
Okay. Well, thank you first and foremost for having me here today. It's been wonderful to connect with everyone throughout this whole pandemic. So as you had stated back in March when the pandemic hit New York City, it was quite unsettling for my colleagues, myself, as well as my patients. And so as we were looking to Europe and in China for some guidance, I immediately tasked my staff, my genetic counselor, Kara Amstead, my fellow, Dr. Dinesh Lula, my nurse, Vicki Fackler, and everyone to start outreach to my patients because we didn't know whether or not our rare disease patients, their particular disease would put them at an independent higher risk of severe complications. And so we started to actually do phone calls to all of our patients to start to give some guidance about reduction of exposure and risk, what to do in case they were exposed, what to do if they became sick. And because we were doing this over and over again, we made over 200 phone calls within the first couple of weeks. I partnered with Check Rare to try to put that into a webinar to disseminate it even further to not just my population, but to anyone who needed some information in real time. And so the ways that impacted my clinic. Obviously, in New York City, the travel to and from clinic for assessments, for blood work, for infusions was very scary for our patients. They were told to shelter in place, to avoid going out unless they really needed to do so. So NYU quickly converted to telemedicine, which was amazing. Within a week or two, being able to start to see our patients through video visits and to manage and to talk about what was going on with them and how to get them help. Infusions were a little bit more difficult because we had a combination of infusions that were clinic-based infusions or home-based infusions. And each of those had their own obstacles. Our patients were scared. They were scared because they didn't know if they were going to have a complication or not from COVID. So we, again, worked with each patient. But at that point, because I have a large practice and standard of care infusions, I work with several pharmaceutical companies, I actually immediately went to their caseworkers. And I met with each of the pharmaceutical companies that I work with and said, how can you help me help our patients be safe? And that was critical to partner with pharma in the clinical world, in the commercial aspect. And so they helped me reach out to our nursing agencies and our infusion centers to ensure that they were taking practices to reduce exposure or reduce possible transmission, proper PPE, whether or not the nurses were dedicated. Some nurses were deployed or redeployed, just as I was, where we had to work in the hospital in the COVID wards. So we wanted to try to separate those nurses out if possible so that our patients were not interacting with potentially exposed nurses. And that's not always possible. Also, how do we mitigate travel? Can we get dedicated travel, mass transit and subway systems? We were not really, patients were very fearful of that. Sometimes I did convert to home infusion as well. So that was in the clinical world. And of course, I'm conducting research. And I think it's important to know, I'm going to speak very general here because I'm doing research in various phases. But this was not just my research group, but the entire NYU system. They immediately, the Office of Science and Research, gathered all of the investigators together to figure out how can we conduct research safely in the pandemic. And that started with these town hall meetings, and we immediately, again, incorporated that video visit, the ability to do remote monitoring for our trials, and then to start to consider our enrolled subjects. How do we safely conduct a trial in the midst of a pandemic? And so with each trial, with each investigator, we had to sit there and go through the risk versus the benefit of continuing or in the study. And once we were continuing the study, how can we adapt the study to reduce risk of not only the patients and the subjects and the family members, but to the healthcare providers and research associates as well? Because obviously exposure can go both ways. We had limited PPE at first. We had certain areas of our clinical units were shut down and converted. So how do we do our assessments for our clinical trials? Are there ways to delegate and to kind of change them or relocate them? And just kind of thinking from start to finish, how can we reduce risk? And so remote monitoring, we did able to do phone visits and telemed visits with our subjects. Some of my colleagues were able to do that. On-site procedures were, again, we know how to handle universal precautions anyway, so we felt comfortable, but how do we make our patients or subjects feel comfortable? And so it was really hard for us because we did have to go through each of our trials and think about risk benefit, continue, halt, or withdraw. If patient, again, informed consent. Patients are able to withdraw if they feel uncomfortable. And so those are the things that were going on. And obviously we worked very closely with the Office of Science and Research, our IRB, our ethics board, and the pharmaceutical companies if it was a pharma-driven, or and there were also NIH guidelines. So, certain studies that were non-interventional might have been halted by some of the investigators. They might have paused enrollment if it was not interventional or not critical. And it was up to the investigator to do that. So, you know, we learned a lot. We also know how to adapt assessments so that we reduce exposure. You know, patients are masked. How do we do certain assessments that require close contact with our patients? And so we're still working it through. It's not perfect, but we quickly came together as a community. We started to think about how to do this and safely conduct research during this time. So I'm going to pause there because I can answer specific questions. But again, this was in real time, trying to maintain clinic and research and safety, and also serve the hospital and serve our community. We were, you know, our hospital was completely shut down to elective surgeries. ICUs were created out of formerly non, you know, IC or monitored settings. We created negative pressure rooms. It was an amazing effort, and I served both a private hospital and a public hospital, and served as a neurologic consultant for several weeks there to help with the neurologic complications. So it was a learning experience. It was tough, but we came through, and we're still dealing with it because we're anticipating potentially another wave of it.
Yeah, oh, fantastic. I mean, it sounds like it was a sort of real collaborative effort, and I think there's a concern about second wave also in Europe, and I'll come over to Tanya now, who's obviously been central as part of the patient organisation as a central focal point of contact for the patients at the start of this sort of pandemic. And maybe you can tell us a bit about what are some of the challenges that you faced. Thank you.
Okay. So thank you very much to Zoya and the team for this opportunity. First of all, just to say that I'm the CEO of the International Gaucher Alliance, and our members are national patient organisations that support patients with Gaucher's disease. And currently we have membership from across the globe, including many developing countries. So we're really aware that we needed to identify what our role as a global umbrella organisation was. So when the pandemic took hold, we decided that our role was really for guidance and information, and to provide support to our national members who had different levels of access to information in their own countries. In the IGA board, it's made up of mostly volunteers, and all of the board members are allocated responsibility for different countries. So each of our board members personally reached out to their allocation of countries to do a welfare check, and to ask how things were in their countries. Because although, as we know, the pandemic was a global pandemic at that time, different countries were experiencing different situations. Rules and regulations were very, very different. So our board members reached out personally, and the reports that they came back with came up with many, many different themes. A lot of them were the same. But there was also some really good innovative ways in which national organisations have decided to support their own patient community. So what we did is we pulled all that together into a document and sort of shared best practice, as we saw this was a good way of supporting our members. So a couple of the main issues for the patient community, and Heather has alluded to this, to some of these as well. Obviously, access to treatment. Patients with Gaucher's disease either have fortnightly infusions or they're on oral therapy, but the majority of our community are on fortnightly infusions. And immediately we recognised that many patients were put in a position where they had to miss their treatment. So obviously there was a huge anxiety there about the impact on their sort of clinically. Yeah. Some patients decided to switch to oral therapy if their physician just said that was going to be something that they could do. So that was obviously very positive. The hospitals were extremely proactive in many countries, and Heather's talked about it in the US, in terms of getting in contact with their patients about the situation with access to therapy. Unfortunately, many of our members are in countries like Africa as well, Sudan, where literally there was no communication at all. Hospitals literally shut down and all resources were switched to COVID. So in countries where patients had to go into hospital for their treatment, which is a large proportion of our community, literally there was just no access at all, and in some ways no communication.
Right.
So we do, in some countries, and Heather alluded to this, and also in the UK and some other Western European countries, we do have access to home therapy.
Yeah.
But also, you know, this did have some challenges because some patients were shielding, and they were anxious about nurses coming in, even though they may have had PPE. So there was lots of discussions with their clinical team about that. However, home therapy sometimes obviously isn't available in many countries. In some countries, they have home therapy and nurses come in. But in some countries like the UK, we have many of our community who actually self-infuse themselves. So they were still able to get deliveries, and they were still able to have access to treatment. So there was a lot of differences in people's ability to have access. Now, in some countries, particularly like the UK, we've done a big push in trying to make patients independent. So patients make up their drug, they infuse themselves, and then they finish off. Now, this has been a challenge. Some patients like the nurse to come in, it's part of their routine. However, what we have seen now as a result of the pandemic is that more patients who were having nurses now want to become independent, because they're aware that there potentially could be another wave, and therefore they want to guarantee that they can continue their treatment. So access to treatment was a massive issue for our community, and home therapy seemed to be one of the things that we as an organisation could really focus on to try and push globally. So we reached out to our experts through the European Working Group on Gaucher's disease, and we made a call to action for them to write guidelines so that we could distribute those out to our members, who could then work with their clinical teams and their governments to try and bring home therapy to all patients across the globe. We also ran a webinar where we invited our members to attend, and a couple of our members from France and Greece who had already taken up some work in bringing home therapy into their countries actually facilitated that webinar, and there was a lot of document sharing, so that was really successful. Supply of treatment was something that people were really anxious about.
Yep.
So we reached out to the global pharmaceutical companies to get their reassurance in writing that there wouldn't be a shortage. And we had very positive feedback there. However, obviously there has been some challenges with borders being shut. Particularly, we have found this in with a lot of our charitable access program patients, where maybe that it's been very difficult to get messages out to them because there are no patient groups in those countries. So as an organisation, we've reached out to our members to tell them and to continue to give them information.
Okay.
I think, and just finally, on the last point, I think one of the biggest things is our patients understanding their vulnerability and what risk they were at. And we turned to our experts here who knew about Gaucher's disease and asked them to make a statement that we could then distribute to our global community about their risk. Obviously, there are individual patients who have individual risks, but it was to have one voice from experts, you know, to patients. And I know this was done through the EWGGD, and also Heather's talked about it in the US. So the other thing that was challenging for our patients is, should I shield, should I not shield? Am I vulnerable, am I not vulnerable? And there were mixed messages sometimes coming out from the different governments. And this is where working with their clinical team was really, really important, because the clinical team knew the individual patients, and where there was a challenge with communication, we looked to our experts to ask for individual patients in countries where their experts maybe didn't know much about Gaucher. And finally on this point, in terms of the national organisations, I'm obviously a director in the UK of the association. We worked with all of our clinical leads to ask them to do regular national webinars where we invited all our patients to try and keep giving them up-to-date information about shielding, vulnerability, what was happening in clinic, those types of questions, just to continually provide support to our community from experts. So I think I'll stop there, Zoya.
Thank you, Tanya. It's fantastic. And we're already getting some questions beginning to come in. So we'll just carry on, and then we'll address some of the questions. So keep your questions coming in, everybody. Some very good questions. So we'll go now to, thank you, Tanya. So now we'll go to Emily Crossley from Duchenne's UK. And I know the Duchenne UK is very active in terms of clinical trial network, and has been successful in terms of managing some clinical trials. So maybe you can give us a bit of an overview of what the impact has been on the pandemic from your perspectives. Thank you.
Thanks, Zoya, and thank you, Marcia, for inviting me to give our perspective. I thought I would just give you a couple of vignettes just to sort of illustrate some of the challenges that we've been facing. Firstly, we are the biggest funders of a repurposed trial, tamoxifen, as a potential treatment for DMD, and the trial was going really well. The recruitment was very successful. It was a randomized controlled study in 9 countries. Unfortunately, when the pandemic hit, we haven't quite hit recruitment targets. So we're currently now in discussions about what we do with the number we've recruited so far, because clearly we haven't been able to recruit anyone since February. We've managed to send the medicine to people at home, so they are continuing to dose, but they haven't been able to go to clinics for their functional outcome tests. So that is going to be challenging, and we're sort of monitoring that on an ongoing basis. We had quite a distressing case in the UK of a mother whose son was on a clinical trial, and the company just before lockdown announced positive interim data from the study, which obviously was good news for her. But then unfortunately the clinical site stopped all clinical trial visits. So she then spent the next 3 months in a kind of limbo, waiting to see whether or not her son could re-access the treatment. And I think that was quite common across the board. In terms of the impact of the pandemic on health, I would say it's twofold, really. I would say it's impact on physical health and impact on mental health. And I won't repeat too much what Tanya said about feelings of social isolation and abandonment. And we certainly moved a lot of our work into patient support. You know, our main focus is funding research, but we ended up doing weekly webinars to try and guide the community in what was pretty much a vacuum of information. And, you know, I just wanted to highlight that you know, a number of many families were distressed about the lack of PPE and the lack of support for them. And what struck me early on in the pandemic is that it seemed that the government was unable to provide what patients needed in terms of PPE and support for the vulnerable. Yet they did find the time to make an amendment to the Children and Family Act, which meant that local authorities were no longer legally obligated to look after children with special needs, but it was just downgraded to their reasonable endeavours. And I think this made families of patients with rare disease feel extremely vulnerable, that their hard-won statutory rights had been undermined in this way at a very time when they felt most vulnerable. So there was also that element of it which really severely impacted the community. And then of course there's the actual practical implications. So a lot of older patients with DMD are on ventilators, and a number of our patients were denied filters for those ventilators, and that's obviously extremely stressful and potentially life-threatening. And I think in fact a fifth of all rare disease patients did have their medicines interrupted by the pandemic. So there was real emotional and physical costs of COVID-19 to the Duchenne population. And I'm going to stop there, Zoya, because I know we're short on time. So if anyone wants to ask anything, do feel free. But I hope that's contributed.
Thank you, Emily, for that overview. And what was the reason that you said on ICU they stopped decided not to continue treatment in some of the patients? What was the reason behind that?
Well, I think it's because the trust just felt that they hadn't set in measures yet to safely be able to administer treatments to boys on clinical trials, and that clinical care had to come first. I mean, the clinical, the network of doctors in the UK is very robust. We have the North Star network, and at Great Ormond Street, where my son is treated, they've moved to virtual appointments, and that seems to have gone well. But I think the priority really was on those clinical appointments, and so all medical research as such was put on hold. However, the clinical community is very adept at adapting, and I know that a trial at Alderhay, which requires an infusion, is now underway, and parents have been reassured that they will be the only family in the room, and they are taking very tight precautions to ensure that some of those trials can continue.
Mm-hmm. Thank you, Emily. We will come back to you with more questions. I just want to go now to Professor Huma Chima, who I think is there. We can't see your video, but I know she's dialed in. Are you there, Huma? There we are. Thank you for joining us, Huma. I know it's late in the evening for you, and you've been obviously right in the thick of it and managing your patients in the hall. And I think it'd be really interesting to hear from your side. We've obviously heard from the US, UK, so it'd be really interesting to hear, what are the challenges that you've seen in your patients during this pandemic?
My apologies. Hello, that I disappeared.
Hi, Huma. That's okay.
But there's some emergency patients which I came in to see, so that's why
that's fine. Patients,
you see me in the clips and the mask. Yeah, I was listening to everybody, and I'm impressed with all the kind of work which everybody's been doing. In Pakistan, I would say that we've been very lucky generally in the pandemic. You must have heard that we are down to less than literally 5% now. But when we were in the peak, thankfully, because our rare disease patients like Gaucher patients who are on ERT, we have about 62 on ERT, and they're dispersed over some weeks, and everybody doesn't come on the same day, and they are coming in on Wednesdays of the week. Since they come from all over the country, there are only 3 patients who had an issue that for 2 months they didn't get their ERT. The rest, because these 3 patients were from the Sindh province, which is about a 22 hours journey. Normally they come in and they take their enzyme and they leave and they come back for follow-up in 3 to 4 months. Somehow a couple of them were not able to take their therapy. For one of them, we actually transported it with somebody, and the other one didn't get it for 2 months. The rest of them actually continued to come in, and we didn't have any problem. None of them got COVID, and the shielding was there, but generally the Pakistanis have, unlike, I was listening to everybody, they seem to have the opposite direction of xerophobia of COVID. So we had to keep telling them to wear masks and be a little more phobic than that. But we haven't had a problem. So I wouldn't say that we ran into obstacles. The biggest issue has been more on any simple issue of these kids, like, or any other kid in Pakistan. COVID has been so much overwhelmingly preoccupying everybody. I think it's the same thing with adult medicine, with pediatrics. You know, poor kid has any other thing apart from, you know, everybody's just focusing on COVID. So a lot of kids I think they got pretty much neglected in their other issues, vaccinations, they didn't get their vaccines, their routine checks. And everybody, the doctors were not available, but we had in Children's Hospital, in my clinic, and all my clinicians, all my students, they all were giving online service. So everybody has a mobile phone, a smartphone in Pakistan. Even, you know, ordinary cab driver or is sending, the street hawker will have the mobile phone. So they all have the WhatsApp on it. So they can just talk on and send a message. They love sending the audio messages in Pakistan. So you reply to listen to a long audio message in the middle of something. But that at least gives them the support, that there is this constant emotional support that is given by the clinicians. But actual visits were less. And then if they had simple things like, okay, they have a tummy pain, or they have anything, they have diarrhea, or somebody's vomiting. 2 of my patients just landed after the COVID got better, and they actually had a massive amount of abdominal lymphadenopathy, and he had been having tummy pain for almost 2 months now. And he has these huge Gaucheromas, despite being on ERT, in the liver, spleen, and lots of lymph nodes. So I asked him, you didn't contact us? And he said, well, we weren't sure whether we would be entertained, and you know, we took the ERT and we were giving it, but they're living about 12 hours from here. So the normal services which we gave to the children, even adults, everybody was suffering. So I think this happened everywhere in the world. Yeah. Anybody who has anything other than, you know, so you're just doing COVID, and COVID in Children's Hospital happened to we hardly had any pediatric patients with COVID. Like, our hospital is an 1,100 bedded hospital. And at a given time, we would only ever have 3 patients in the COVID unit. So total, we might have treated 16 who were sick enough, and 20, the rest of them were very mild. So 22 patients in the entire COVID duration. But the entire focus of the government and the entire focus of the administration is COVID. So every finance, everything was directed towards that. We didn't even get the infusion sets for giving ERT. So we got some, you know, eye pitched in, some donors pitched in. Nobody was bothered about the other usual stuff. So it was too much COVID. And I think we didn't have much of COVID in the pediatric population in Pakistan, but the overwhelming attention of the public, of the government, of the health care providers was COVID. So I think in a pandemic, everything else gets neglected. The simple things get neglected. Nutrition of patients gets neglected. We did face that. Then the government, in this entire process, all the projects that we had applied for rare diseases, they're all been cancelled. They have this uniform answer that every penny has gone towards COVID. So before also we had very little help from the government, and now they have sort of written it off. So in the future, probably I'm thinking that I might have to move some of the ERT infusion therapy into above my office where I do the clinic, because the government is so tied down for the next 1 year with the budget that the fallout of COVID is going to be enormous on our patients. So as far as these things go, yes, they will have a major impact. We were getting some help with therapy, which we have been told that in future not going to happen. And research is obviously something that totally is on the hold. It's not just because it's on the hold because of the, I think clinicians overwhelmingly got so much occupied with webinars, and there were like 6 webinars in a day, and everything was related to COVID. And I think all other research was also on the hold. Now that things are better, but I see a big economic fallout, which we are going to see in Pakistan. So that's
thank you, Huma. And has there been a move towards mobile remote monitoring, as like Heather mentioned, and more home infusions?
No, the home infusion, unfortunately, in Pakistan, it's getting a nurse to give a home infusion is so costly that they might as well call and the doctor. So some of them who have relatives who are nurses or paramedical staffs or something, they have done that. But majority, because as I told you, things weren't really closed in the periphery. Main cities, the hospitals, all COVID, but the doctors and the patients in the periphery who had access because we had given them the enzyme, they were giving it. So the doctor were there, let's say in a remote town where our Gaucher patient is there, they would go to the doctor and get. Our towns and out there from the main cities hardly had any COVID. So they were more frightened to travel towards us than to actually go out to the clinic in their cities. So we didn't have this. The big issue is the overwhelming focus that everybody gave. And as a result, a lot of neglect of none of my patients, including my rare disease patient, got their vaccinations. They all missed out on their vaccinations.
Yeah.
So if their supply of anything was finished, like we give them donations for nutritional rehab. They would come for ERT. They wouldn't come for the nutritional rehab donation. We give them special milks for high calorie milks and all the donations. So they were a bit frightened of traveling out for that. But things are now better, and they're coming out.
Yeah. Okay. Thank you, Huma. I'll just try and address some of the questions now that are coming in.
One thing, if I can put in, Zoya.
Yeah, sure.
The kind of help which rare disease patients we would expect from your pharmaceutical industry, that we would be stuck with some things, that kind of hand never reached out actually. Why? I don't know. I mean, I think, I don't know, maybe somebody has an answer to that. We waited for that one email or message saying, is everything okay, and does anybody need any help out there in the rare disease community?
Yeah, I think Tanya will be able to answer that. Tanya?
No, I was just quite surprised actually, Huma, that you mentioned that, because one of the things that we did is that we reached out to all of the pharma companies and said, can we ask you to reach out to your national patient organisation and the clinicians to make sure that they have everything they need? And we were told that would be done by all of the companies. So it's really interesting that hasn't happened in Pakistan, because I do know it happens in many other countries. So that's something I think with maybe the LSD patient group that we can try and address for Pakistan, because from our point of view, the pharma companies were very supportive in many of the countries. Okay. They really, they were really proactive. And they also, for like in the UK, we had access to emergency funding to help us as well, because it put an enormous pressure on us as patient organisations to support our community. So I think that's something that really needs to be actioned, after this call, to make sure that if there's a second wave, is that the companies are proactive, because you do have companies active in Pakistan.
Can I say something? This is Heather. So I felt like in New York that there were people who were not believing that this was going to be a problem. So those of us who were early looking at it were considered maybe we were overblowing the situation. But I started meeting so I proactively reached out to my pharma, because they've supported me before whenever I've had an issue. And as soon as I sat down with each company, they escalated it to the more national level. And then I had meetings with the national level people, and they were listening. So you might have to reach out maybe to make that initial call, but that's what I did. And then that led to, actually before we had the alliance built, we had a Gaucher meeting with some of the other Gaucher experts in the US. We started to have a weekly call and an every 2-week call. But with pharma, I met with them each week. I have 185 active patients, and 135 or 135 we got response from. 90% are infusions. 26 were COVID. I had 1 death, and I had a varied between asymptomatic to severe, moderate. We did not hospitalize everyone because we were overrun. So we had a very different experience. So it's, I felt that they were responsive because I had a patient who was in a facility, and everyone started coming down with COVID. She's a child, she's pediatrics. I saw in our hospital quite many hospitalized children with COVID. Yes, not as severe. I had, a patient was intubated. MIS-C became a problem, the multisystemic inflammatory disease of child. So we were seeing those cases. It was definitely a very, our pediatric ICU became up to age 32 to accommodate, we were completely overrun. And so we were at capacity. So when, it was a very real fear for our patients that if they got sick, they couldn't, they would have to come to the hospital and then, then either be in the waiting room with other COVID or whatever. It was definitely a different feel from what you were explaining in Pakistan. And we didn't know how to guide our patients initially. Obviously, people with pulmonary dysfunction are MPS patients, our Pompe patients we were concerned about, or Gaucher, if they were on treatment, what were their risk factors? We weren't sure. So there was other comorbidities there that led to maybe worsening. But I want to say that we felt supported. National Gaucher Foundation, the IGA, really supported us through this. And for the research, honestly, I'm very proud of my team because we were able to conduct our research. We did, like you said, it became all about COVID, right? Because we were at capacity with hundreds of intubated patients with COVID, but yet we were still able to conduct critical research during this time. Yes, certain things might have been paused or slowed for non-interventional or things that were startup, but I felt pretty good that we were able to conduct some critical research. And I know we'll talk a little bit later about some other research coming down the pike and how to do that. So it was a different experience here in New York for me.
I think your experience is different because yours is not a pediatric hospital. You're dealing with adults and children, isn't it? But in a children's hospital, because yes, even the MISC patients are COVID negative. By the time they come in with MISC, they're COVID negative. So we did have our share of those, but because it's a children's hospital, and then for our Gaucher patients in our rare disease community, particularly which is on ERT, our hunters, very few hunters, but mainly the Gaucher who come in, we have a separate system of them coming in any case in their infusion rooms. So they have a separate gate and they have a separate entry. They do pass through the corridor but this is a children's hospital. So in any adult facility, you'd be more worried about kids coming in and any of the adult hospitals would be full of COVID during the COVID pandemic. Ours is a children's hospital. So mainly the research again in our hospital was focusing on, we're getting data on the MISC and get all the patients of the MISC and see how this happens. And then we were part of the different limbs on whether you're going to use chloroquine in them or, you're going to use it. So all those things were happening. But regarding the exposure, it was far less because you are dealing with lots of other patients sitting in the waiting room. That doesn't have, our Gaucher doesn't sit in the waiting anywhere. He walks in with his card. This is what I created when we made the unit for them. So they come in with their card, they come straight upstairs, they never get screened anywhere, and they come to the ERT room. Then the nurse is familiar with them, looks at their record, and then takes them to the infusion room. They get all the tests done if they need them at that time, ultrasounds. They get their infusions. The data gets recorded, they say bye-bye, and they go home. And they then use so this entire process doesn't take them through the usual doors or they're not stocked anywhere. So that's a good way. But then again, because of the children's hospital, they weren't really exposed. So that experience will totally be different if you work in a general hospital where part of it is pediatrics.
Yeah, we have a separate infusion center that's actually outside of the hospital. So for my NYU, but 90% of my infusions are home infusions because it's actually more economical, or the insurance companies drive that. So none of my patients were exposed in the hospital, so that they were exposed in the community, especially because of there was one of my patients in a particular religious community had said that it was during a very religious time where there was a lot of celebrations and there was a lot of exposure in that community. And so it did run rampant. But I do agree. Actually, most of the patients that were exposed were outside the community, not there. And thankfully, and I will say, with the mitigation factors, even though there was such a scare, the patients didn't want to go either receive a nurse in their home because they were afraid of it, or go to their infusion center. So some of my patients did halt, but then resumed after. No one got exposed through the infusion centers, thankfully, at least the ones that I knew of. But it's different. Thank you for clarifying, because I was wondering why the difference, because it does make sense. We have a children's hospital, but it's still, it's connected to the adult hospital. And so they had to overtake some of the facilities to accommodate. We also had, tents in Central Park, and we had the Jacob Javits Center. It was an unbelievable time. But yeah, so I just comment there.
Thank you, Heather. Thank you, Huma. So I'll just go to some of the questions now. A question from John Wise to each of the panelists, who says, given the many and different challenges you and your communities have had to face during this pandemic, which one would you say has been the most significant? And just in just a couple of minutes, each of you, perhaps you can think about what's been the most significant challenge, if you had to pick one.
Shall I start?
Yeah.
Yeah.
Thank you.
I mean, there's obviously a lot, but I think from the patient community, one of the biggest challenges was access to information. Access to, the everything was changing so quickly, and it was as an organization wanting to be the sort of main source of information to get out to patients. It was keeping up with that, really sort of interpreting what the information was coming out from the different governments, the different experts. Yeah. Patients asking questions about where they can get information. Yeah. And so for us, it was really because you have to be very careful when you provide with information, especially when you're a trusted organisation. So for us, exactly. that was one of the biggest significant issues.
Yeah. So getting hold of the correct, accurate information. Yeah.
I agree with that completely. That's what prompted me to even just do those webinars. Because at the end of a 10-hour day in my office, just trying to get information, not scaring the population, but I wanted the young people to take, some of the precautions. I think that was the most, getting accurate information. It was a real-time experiment. And that's very scary. It's an uncontrolled experiment in a way. There's this novel virus hitting our patients, and we are trying to understand their risk and how do we not cause a mass hysteria, but also how do we make sure that they reduce their risk. Certain populations, like the MPS population, I feel they sheltered in place immediately because they're at high risk of flu even, right? So it was more of my well-controlled Gaucher. How do I not instill a panic, but how do I take care of them? And the information was changing daily. It was changing so quickly, even for us as healthcare professionals. How do we protect ourselves, let alone how do we protect our patients? But I'll let someone else comment.
Zoya, I can jump in now. So
yes,
I
please.
completely agree with what Tanya's comments about not having information. I think from the perspective of a charity that funds medical research, I think the implications of the pandemic are unfortunately going to be huge. Nearly all of the projects we're funding have asked for no-cost extensions. Animal colonies have had to be sacrificed. There are going to be huge delays on outcomes of clinical trials. Ultimately, you know, huge delays to access to treatments. And unfortunately, I don't think, you know, if there is a second wave, the implications could be even greater. So that really does worry me. And I think it's a massive blow. You know, in Duchenne, we have hardly any treatments for this disease, and some that we do come with really devastating side effects. And you know, we need more treatments, and this is just going to add significant delay to a disease which is hugely progressive, as you know, and time is the one thing we don't have. So I think that's the biggest threat, and we don't really even know yet how big it is.
Yeah, thank you, Emily. Just have a comment from Lisbeth Siderus in the comments saying that at present we still do not know the risks. We need to get better systems to register regular care in daily practice. We have just 4 minutes left, and I'd like to just quickly turn to perhaps talking about the future. And I guess the concept of this webinar was talking about preparedness. And there's a lot that we've learned, I think, just from our discussion today. And a lot of common themes have come out in terms of having access to accurate, regular information for patients, home infusions, remote monitoring, and hopefully a lot of these changes will be positive changes that will continue in the future. So I'm just wondering, I have a question submitted from someone around gene therapy. I think we know that there's, I think all of the panel, you're involved either as researcher or involved somehow in gene therapy in your disease area. What do you think the impact of this pandemic will be on that research? And yeah, so I'll just open that up to anybody who wants to answer. Heather?
Yeah, I mean, this is on the minds of all of us in the rare disease world, to the point we cannot have our research slowed down. I was talking about the disease states that have standard of care therapy, but I am a neurologist by training. The neuronopathic lysosomal storage disease is the other. It is critically, it's an unmet need. Our children are rapidly progressing. I actually feel more confident coming through this now about how to conduct a clinical trial safely in the midst of a pandemic. And it's an odd sense of that I'm having where we've learned a lot, and I think we need to power through. We have to be able to conduct this research. It's critical. And to work with the individual academic institutions or pharma to do it safely, because we can't halt rare disease research. We're going to have other issues come forward, you know, other pandemics, other things, and we need to continue this, not just for science, but for our patients. So already we're working to figure out how to do this safely. It's going to be impacted. It will be, but I think we've learned a lot. We have to incorporate more of these remote monitoring, the visits and everything, and take a look at what kind of assessments we have to do. We have to move forward and work together as a team to figure out how to do that. So,
yeah, thank you, Heather. Emily?
Yeah, I fully agree with what Heather's saying. In fact, we just announced a £500,000 project with the University of Florida to ironically look at the various immunological issues that come hand in hand with gene therapy. But I agree with Heather, these are challenging times, but we simply can't stop. Yeah. You know, we are on the brink of some amazing breakthroughs, and you know, we just recently take part in a preference survey for patients, and you know, patients desperately want and need new treatments, and they have a high risk appetite for that. Now, admittedly, that was carried out before COVID-19, but we can't ignore that message. You know, patients need treatments, they want access to innovative therapies, and they desperately want to take part in clinical trials in order to advance that. So Yeah, I fully agree.
So thank you, Tanya. And Tanya, I don't know if you've got anything to add around the...
I think the only thing I would just add is that, you know, we are an exciting time for Gaucher. As Heather said, you know, we have neuronopathic Gaucher's disease for GD2 and GD3, and you know, we're really excited about that. We also have gene therapy for type 1. I think one of the things is the safety of clinical trials, but I also think we need to really think about the recruitment and how we get patients recruited, particularly from these, you know, from these subgroups that are sort of more ultra rare. I think that will be really, really challenging, and we can't let COVID delay recruitment, because the longer we delay recruitment, the longer the trial will be, and the longer access will be then to the patient population if we have good outcomes.
Yeah, exactly. Some comments coming in on the chat, basically agreeing with what I was saying. A comment from Susan Tansey saying, I agree with Heather in that remote visits and monitoring are helpful to continue our rare disease studies and hopefully mitigate some of the issues due to the pandemic. Unfortunately, we've run out of time. I've really enjoyed our discussion, and I want to say a big thank you to all of you panelists for taking time out of your busy schedules. There's a lot more to discuss, and hopefully we can have another follow-up discussion, I think, around, particularly perhaps around the ethics of gene therapy, access to medicines, topics that came up, accurate information, supporting physicians in Pakistan. So there's a lot more to discuss, but unfortunately we've run out of time. So I just have to do some housekeeping and mention that the meeting will happen in 2 weeks' time, which will be around oncology, impact of COVID on oncology patients, another special population, and to ask you all to complete the survey. So thank you, wishing you all a good summer break, and well prepared for the next wave. Okay, thank you everybody.